Okay. Good evening, everybody. In previous classes, we have discussed about colorectal cancer introduction. We have discussed few anatomical parts of colorectal cancer, and we have also discussed the pathogenesis one mechanism of colorectal cancer. So today we'll continue with the colorectal cancer pathogenesis because few pathogenesis concepts were remaining that we will complete in today's class, and we'll also cover the clinical presentations and diagnostic criteria and staging of colorectal cancer. And with that, we'll end this uh, today's topic with the treatment. Okay, so let's begin our session with the remaining concepts of colorectal cancer. In previous classes, yes, I already discussed that anatomical features. If you see, the colon has mainly divided into six parts. In that, we have cecum and ascending colon, and we have transverse colon and descending colon. Okay, and we have sigmoid. This is sigmoid colon. Here, this part is sigmoid colon. Finally, rectum and anal canal. Okay, so in previous class already I told that see the prevalence of colorectal cancer increases from rectum. Actually, in rectum, the colorectal cancer probability is very high. And then in the tumors are seen in sigmoid colon. Okay, sigmoid colon. Initially, it is very high in rectum, and then it is seen in sigmoid colon, and then in descending colon, descending colon, and finally in the transverse colon and ascending colon, so you can see the prevalence of tumors, particularly it is very high in rectum and then in sigmoid colon and then in descending colon, and in transverse and in ascending colon the chances of getting cancer is very less. Okay, so this is the importance of prevalence of colon in these areas. In rectum, the probability is very high, that you have to remember. Okay, and in previous class already we have discussed, if we see the transverse section of colon, we can find these different layers. We have mucosal layer, mucosal layer, submucosal layer, muscularis layer, and finally serosal layer. So these are four layers, and these layers are very important for us to identify the stages. In stages, they are very important. Okay, so these concepts we have already discussed in previous classes, and we have also discussed about colorectal polyps. Okay, actually colorectal polyps are non-cancerous substances. These are non-cancerous overgrowth which are seen in colon. Okay, so this, if patient has polyps, this will again lead to formation of carcinoma. So all these points we have discussed in previous classes. And in polyps we have, actually in polyps we have neoplastic polyps and non-neoplastic polyps. Neoplastic polyps and non-neoplastic polyps. Actually, these are neoplastic polyps which are mainly divided into three types. In that, we have tubular adenoma or tubular adenoma polyps. We have villous adenoma polyps, and we have tubulovillous adenoma polyps. Okay, these are three types that we have discussed in previous classes. And yes, in previous class, I also explained you about the genes which are responsible for colorectal cancer. Mainly, if you see EGFR gene, this is an oncogene. The activation of EGFR gene or ERBB1 gene, this activation can cause colorectal cancer. And KRAS gene, NRAS gene, CMYC gene, and NMYC gene. So these are another oncogenes which are responsible for colon cancer. And in tumor suppressor genes, already we have discussed about APC beta catenin protein mechanism in formation of colorectal cancer. So here the suppression of APC gene, this is very very important. Suppression of APC gene causes approximately 80% of colorectal cancers. So suppression of APC gene is very very important. This will cause colorectal cancer, and along with that, we have few other cancers associated with other colorectal cancers. Okay, other genes. So mainly here APC gene we have to remember. And here we have MSH2 gene, MLH1 gene, PMS1, PMS2, MSH6. All these are another tumor suppressor genes which are responsible for causing colorectal cancer. These I'll explain you in microsatellite instability mechanism. Okay, so these genes are very much important. Here actually in tumor suppressor genes, particularly APC gene deficiency of formation of APC gene and deficiency of formation of MSH2, MLH1, PMS1, PMS2, MSH6. This deficiency of APC gene causes one type of cancer. 80% of colorectal cancer occurs, and that is occurring due to the mechanism of beta catenin mechanism that we have discussed in previous classes. And due to the deficiency of MSH2 and this, it will cause microsatellite instability. This is second mechanism. So based on this involvement of different types of genes, tumor suppressor genes, we have two different types of mechanisms, and along with this, we have other types of mechanisms also. But mainly, we focused on these two. Actually, in previous class, what I explained you, we actually we have two main mechanisms in development of colorectal cancer. In that, the first mechanism is APC beta catenin mechanism. This is first mechanism, and majorly 80% of colorectal cancers are mainly associated with this mechanism. This mechanism already we have discussed in previous class. Let me revise. In APC beta catenin mechanism, what happens? Actually, this APC, when APC gene mutation occurs, when this gene mutation occurs, it will not produce APC proteins. When APC proteins are not produced, these APC proteins will not degrade the beta catenin proteins. Actually, these beta catenin proteins are responsible for formation of cell proliferation. Cell proliferation. Beta catenin proteins are important in cell proliferation. Once cell proliferation occurs, immediately APC proteins will degrade the beta catenins. When APC gene mutation occurs, APC proteins are not produced, and in that, due to that, beta catenins are not degraded, and with that, cell proliferation is not stopped. So cell proliferation keeps on increasing when beta catenin proteins are not degraded, and that beta catenin overactivity can be seen, and with that, cell proliferation increases, and it will cause neoplastic cell formation, or the cancers which are seen in colorectal cancer. Okay, this is first mechanism. Okay, and remaining second mechanism is microsatellite instability mechanism. Microsatellite instability microsatellite instability mechanism, which is also called MSI mechanism. Okay, that this mechanism I'll explain now. Okay, so these two are main mechanisms here. APC beta catenin mechanism, 80% of cancers are seen due to this mechanism, and remaining 20% of colorectal cancers are seen due to this mechanism. Okay, and this microsatellite instability mechanism are responsible with MLH1 gene. Okay, MLH1 gene, MSH2 gene, MSH2 gene, MSH3 gene, or MSH6 gene, MSH6 gene, and PMS2 gene. So these are all different genes which are mutated, and with this mutation, it causes microsatellite instability. Okay, I'll try to explain. Okay, so in previous classes already we have discussed about the risk factors of colorectal cancer. In risk factors already I told, in geographic variations, people with Northern American people and Northern European people are having high risk of getting colorectal cancer, that I already explained, and remaining populations are having less prevalence. In dietary sources, I already explained, patients who are taking less fiber diet and high refined carbohydrates and high fat diet are having risk of colorectal cancer, and pre-existing adenomas or pre-existing polyposis, that again may lead to colorectal cancer. And here this fourth point is very important: hereditary non-polyposis colonic cancer, which is called non-polyposis colorectal cancer. This is very, very important. It is actually a hereditary condition. It is autosomal dominant condition. If patient is having this autosomal condition, in these people, patient may develop colorectal cancer. Colorectal cancer. The probability of causing colorectal cancer is very high in patients who are having HNPCC. If patient is HNPCC positive, which is also called as Lynch syndrome, if patient is having Lynch syndrome, they are having high risk of causing colorectal cancer. Very, very important risk factor. And next is familial adenomatous polyposis, which is also called FAP. This is also autosomal dominant polyposis syndrome. Okay, in these patients also, patient will have high risk of causing colorectal cancer. This is another major risk factor. And there is mismatch repair cancer syndrome. Even these also can cause colorectal cancer. It is a rare inherited disorder. It is a turcoid syndrome. It is called turcoid syndrome. So patient with pre-existing adenomas, patient with Lynch syndrome, patient with FAP, patient with turcoid syndrome, they are having high risk of causing colorectal cancer. And in other factors already we discussed, excess intake of alcohol, excess intake of smoking. Okay, patient having Crohn's disease or gastric related disorders, peptic ulcer, or fungal infections, viral infections, particularly to GI tract. Okay, all those are other risk factors which may cause colorectal cancer. In that, dietary factors plays very, very important role. In previous class we have already discussed, and these hereditary conditions, they may cause colorectal cancer. These are risk factors. Now, yes, in previous class already I explained you the APC mutation and beta catenin mechanism. When APC mutation occurs, APC proteins are not synthesized. And when APC proteins are not synthesized, these APC proteins will not degrade the beta catenin protein. Beta catenin protein. This beta catenin protein actually causes proliferation of cells. So, in the mutation of APC gene, APC proteins are not formed. When APC proteins are not formed, beta catenin is not degraded. When beta catenin is not degraded, beta catenin activity increases, and with that proliferation increases, and it causes carcinoma of colorectal cancer. Okay. This is important. And the next mechanism in previous class already I stopped here, I think. Microsatellite instability mechanism. This is the next very important mechanism through which patient develops colorectal cancer. Actually, it is microsatellite instability is a molecular feature which is seen in colorectal cancer. Molecular, it is a molecular feature. This microsatellite instability is seen, actually it is a genetic material, and in these are microsatellite instabilities are seen in genes. They are seen in genes. So they are molecular features. These are molecular characteristic features in colorectal cancer. If anybody has this microsatellite instability features, that means they are having colorectal cancer. Simple. Now I'll try to explain. You see, actually, just imagine this is a DNA. Okay, when DNA replicates, it forms the DNA products, right? So here, when DNA replication occurs, few base pairs are formed in the DNA strands. So in this, what happens actually? Whenever replication occurs, in the replication, few mismatches are seen. Mismatches mismatches are seen in the DNA strand. Whenever these mismatches are seen in the DNA strand, what happens? We have one protective mechanism which is called mismatch repair system, which is called MMR system. MMR system is mismatch repair system. This mismatch repair system, what it does, it will repair these mismatches and it will again cause repair and it will cause replication. Okay, it will cause replication. During replication, just it is very easy. During replication of DNA, there are certain mismatches we can see in the replication strands. So if mismatches are seen, that mismatches will be repaired by mismatch repair system. See, when mismatch repair system deficiency is seen, when mismatch system deficiency is seen, this mismatch system repair is stopped, and with that what happens, it will cause, there will not be mismatch repair is not seen, and with that it will cause mismatch. And due to this mismatch, what will happen, it will cause increased activity of oncogene, and it will decrease the activity of tumor suppressor gene due to these mismatches, and with that it will cause colorectal cancer. Simple. Actually, I'll try to make you easy. See, just imagine these are, I just explained you. For the mismatch mutation, these genes are involved: MSH2 gene, MSH6 gene, MLH1 gene, and PMS2 gene. Whenever there is mutation in these genes, what happens? When mutation occurs in these genes, the mismatch repair system is deficiency is seen. Whenever there is mutation in this gene, mismatch repair system deficiency occurs, and when mismatch deficiency occurs, there is no mismatch repair. When me repair is not seen, it will cause what? It will cause instability. It will cause instability, and this instability are considered as microsatellite instability. These are microsatellite instability. Okay, these are microsatellite instability. And in genetic molecular basis, if you see this instability, microsatellite instability is seen, they will suspect that patient is having colorectal cancer. Okay, in normal, if you see, in normal patients, due to the mismatches in the genes, they will be repaired. But if mismatch repair gene, or if mismatch repair system is deficiency is seen, what will happen? They will not be repaired. So they will not repair the mismatch genes, and it will cause microsatellite instability. Okay, so these are microsatellite instability. Just you can see, actually this is the normal mechanism. This is normal mechanism, and this is deficiency of mismatch repair system. Okay, the red side, this side is deficiency of mismatch repair system. When deficiency of mismatch repair system occurs, what will happen? It will cause instability of microsatellite region. And if microsatellite instability is seen, that is nothing but it is causing colorectal cancer. Colorectal cancer. Why this instability of microsatellite causes colorectal cancer? This instability of microsatellite region, what it does, it will cause increment in the oncogene is induced, and it will decrease tumor suppressor activity. Tumor suppressor gene will be decreased, activity will be decreased, and oncogene activity will be increased when patient is having instability microsatellite region. Okay, that's why it will cause cancer. Now we'll see with the staging. In staging of colorectal cancer, actually we have depend on the extent of bowel involvement and depend on the presence or absence of metastasis and histological grade of the tumor and in the location of the tumors. Mainly, it is divided into few stages. Actually, in staging, we have three types of staging systems. Previously, in olden days, we used Duke's ABC staging mechanism. In Duke's ABC mechanism, here actually we have stage A, stage B, stage C, and stage D. We have four stages of Duke's ABC staging. And after that, Asler Kolar staging was started. This is the modification of Duke's ABC staging. And in this, we have again 4 to 5 stages that I'll explain now. And finally, in present day, we are using TNM staging. Here we have staging based on tumor size and tumor involvement and nodal involvement and in the metastasis is there or not. Based on that, we have decided the staging of colorectal cancer. And this TNM staging is the advanced staging, and this staging is mainly used by American Joint Committee Cancer Committee. Okay, a American Joint Cancer Committee is there that will stage the colorectal cancer. Okay, that is called TNM staging, which is commonly used nowadays. So if you see with the Duke's classification, as I told, in Duke's classification, mainly the colorectal cancer is classified into stage A, stage B, stage C, and stage D. In that, this is stage A. In stage A, mainly the involvement of carcinoma is seen only in the it is limited to muscularis. It is limited only to the muscles. Till muscles only it will be seen. It will not enter beyond muscles. Okay, so that is called stage A. As I already told. See the transverse section of colon. If you see, if we have submucosal and mucosal and submucosal layer, muscularis layer, and serosa. Okay, so we have four stages. Involvement of mucosa, submucosa, and muscles is stage A. Involvement of muscles and actual nodes are not involved here. It is mainly associated with muscles. Total muscular layer is involved here, and no serosa is involved. That is stage B, or okay, stage B. And stage C is here nodes are involved, and in stage D, along with the nodes, it is involved to the other metastasis is available here. That is stage D. And yes, next is Astor-Koller staging mechanism. Here in Astor-Koller staging, this is the advanced method of Duke's uh, classification. In this, actually, we have stage A, stage B1, stage B2, stage C1, stage C2, and stage D. In stage A, only mucosa is involved. Only tumor is involved in the mucosal layer. And in stage B1, submucosal layer is also involved. And in stage B2, muscularis is involved. And in stage C1, muscularis with nodes are involved. And in stage C2, serosa is involved along with nodes. Here in stage C1, you have to remember C1 is involving muscularis layer and nodes. And in C2, serosa is involved and nodes is common. Okay, you can see the image, it is very clearly visible. And stage D is the stage where patient will have metastasis. From the colorectal cancer, it will be invaded to the other tissues. If it invades to the lungs or it invades to the liver or to the other pancreas, they are considered as stage D. Okay, and the third staging mechanism is TNM staging mechanism, a TNM staging method. This is the advanced method. Okay, in this we have T. T means it talks about the tumor. Okay, how tumor is involved. So here we have 6 stages. In TNM we have in T initially tumor. If we see the involvement of tumor in that, first stage is TIS, second stage is T1, third stage is T2, fourth stage is T3, fifth stage is T4A, and sixth stage is T4B. Okay, see in T, in first stage is TIS, which is in that only lamina propria, involvement of lamina propria with no extension through muscularis is seen. That means the tumors are seen only in the mucosa submucosa layers. And T1 is in here, submucosal layer is also involved. And in T2, muscularis layer is involved. And in T3, it involves muscularis and pericolorectal tissue. Okay, and in T4A, which is fifth stage, here tumor invades to the visceral layer also, visceral layer, and okay. And last stage, sixth stage is T4B. Here you can see tumor directly invades or adheres to the adjacent organs. Here metastasis is seen. So in T, tumor in T we have TI, T1, T2, T3, T4A, and T4B. These are different stages based on the involvement of tumor. Okay, and in nodes, due to the involvement of nodes, in that also we have different stages. In that we have, if no nodes are involved, that is NO. If one node is involved, that is N1A. If two or more nodes are involved, that is N1B. And if 4 to 6 nodes are involved, that is N2A. If more than 7 are involved, that is N2B. And here actually, here N1C is also there. No positive nodes, but tumor deposits are seen in serosa and in perirectal areas. Okay, so just see, based on the nodal involvement and based on the tumor involvement, they are divided into different stages. And if we see the metastasis in that, in this also we have M0 stage, M1A stage, M1B stage, and M1C stage. Okay, here we have four stages. M0 means no metastasis, M1A means metastasis to one site, M1B means metastasis to two sites, and M1C means metastasis to peritoneal region. More than, actually the peritoneal region is beyond the peritoneal cavity. If it goes, that is M1C. Okay, so these are different stages. Just try to, it is very easy in TNM staging based on the tumor involvement and based on the nodal involvement and based on the metastasis is there or not. Based on that, we calculate. All in previous classes we have discussed this colorectal cancer TNM staging. Okay, now, if you see the clinical features of colorectal cancer, mainly patient who is having colorectal cancer in stage 1, 2, or 3, particularly in 2 and 3 stages. Okay, based on Dukes, in 2 means stage B and in 3 means stage C. Okay, from that occult bleeding is seen. Mainly, see, you can see the bleeding in the GI tract. Occult, this is called occult bleeding. And patients' bowel habits will be stopped. Patients sometimes will have diarrhea, and patient will have constipation. Mainly constipation is seen due to the obstruction. Okay, so bowel habits will be decreased, especially in left-sided colorectal region. We can see these bowel habits. Sometimes loss of weight can be seen. Cachexia, which is called cachexia, and loss of appetite, anorexia can be seen. Patient will not have ability to eat. Patient will not have interest in eating, and patient anemia, weakness, malaise. All these are another clinical features of colorectal cancer. And if you see the another important points in colorectal cancer, see, in colorectal cancer, most common complications are obstruction is seen mainly, and obstruction again leads to hemorrhage. So obstruction and hemorrhage are main complications in colorectal cancer. Obstruction can cause, and this is very very important complication. Okay, and a few diagnostic criteria. If we see, we will go with the stool test. Okay, occult blood can be seen in stool, and per rectal examination is seen, which is also called protoscopy. Okay, we'll send some cameras through the anal region and we'll see the region. Okay, and radiographic contrast media we send through the anal region and we'll try to find out the x-rays. Okay, in that radiological data we can see whether obstruction is there or not, and CT scan is also performed. And in most cases, estimation of CEA, very very important, carcinoembryonic antigen we call it. Okay, so if patient is having carcinoembryonic antigen positive, we can say that patient is having colorectal cancer. But in few cases, this carcinoembryonic antigen is seen, and in few cases it is not seen, mainly in patients who is having pancreatitis, alcoholic cirrhosis, and ulcerative colitis. In that areas we can't find this carcinoembryonic antigen. And just now, if you see the exact morphology, if you see the morphology of colorectal cancer, we can see two morphologies. In that we have right-sided colonic growth. Okay, in right part, particularly in the ascending colon. In the ascending colon, it will cause cauliflower like obstruction. Cauliflower like growths are seen in right-sided colon, particularly in the ascending colon. And in the left-sided colon, particularly in the descending colon, napkin ring type. Here you can see the napkin ring type obstruction is seen. These two are very very important clinical features which can be seen in colorectal cancer. Remember, right-sided colonic growth particularly seen in the ascending colon, and in the left-sided growth can be seen in descending colon. Okay, in left side, napkin ring type of obstruction is seen, and in right side, cauliflower type growth can be seen. You can see in the image also, this is called cauliflower type growth, and this is napkin fold like napkin ring type. Okay, growths are seen in right sided and left sided colon. These are important. And now, if you see the management is very very important in colorectal cancer. Actually, if you see, in past 10 years, there are so many cytotoxic drugs have been improved. In that, in previous class already we discussed 5-fluorouracil, capecitabine, TAS 102, oxaliplatin, and irinotecan. These are different cytotoxic drugs. These are cytotoxic drugs which are approved for colorectal cancer. Okay, for colorectal cancer, always remember 5-fluorouracil is very very effective drug. In some cases, 5-fluorouracil is given. In some cases, capecitabine is given. And in some cases, irinotecan is given. In some cases, oxaliplatin is given. And in few cases, oxaliplatin is combined either with 5-fluorouracil or with capecitabine. Okay. So these cytotoxic drugs are very, very effective for colorectal cancer. Always remember these five drugs. Okay. Now, there is one very famous drug regimen which is called Folfox 4 regimen. Folfox regimen. Folfox 4 regimen. In this regimen, we have platin. One platin is there. In that, oxaliplatin is very commonly used. And one fluorouracil is there, 5-fluorouracil. Okay. And along with 5-fluorouracil, folinic acid is already combined. Actually, this is supportive drug. Folinic acid is supportive drug. So oxaliplatin and 5-fluorouracil. These two drugs in previous class already I told while explaining about Folfox, while explaining about 5-fluorouracil, there is one regimen called Folfox regimen. Okay, in Folfox regimen, platin is always platin is combined with 5-fluorouracil, or in some cases, if 5-fluorouracil is not given, if it is contraindicated, we have capecitabine. Okay, capecitabine. So this is Folfox regimen. This is very, very important regimen. Okay, actually in 5-fluorouracil, initially we'll go with 400 mg IV bolus, and then we'll go with 600 mg slow infusion that is given for 24 hours. Okay, and this regimen is given for 2 days. On first day, oxaliplatin is given, and on first and second days, folinic acid and fluorouracil are given. Okay, you can see here the management. Actually, here this Folfox regimen, oxaliplatin based regimen, oxaliplatin is combined with 5-fluorouracil, or oxaliplatin plus capecitabine. Okay, so these are two treatment strategies, cytotoxic strategies, which can be given. You can see how leucovorin is combined. Actually, leucovorin is the supportive drug, and we have 5-fluorouracil. Actually, initially 400 mg 5-fluorouracil IV bolus is given, and then continuously 600 mg is given on first day and second day as IV infusion. Okay, that is given for 22 hours. Remember this. Okay, remember this table. I'll ask questions from this table. Okay, in final examinations, you have to remember this table. So this is the treatment strategy which is given for colorectal cancer. And along with cytotoxic drugs, we have specific biological agents which are developed for colorectal cancer. In that, we have 5 novel biological agents. About these novel biological agents, actually in pharmacology, we have not started with biological agents. But as we are discussing about colorectal cancer, always remember there is one antibody which is anti-VEGF antibody, which is a vascular endothelial growth factor antibody, which is very, very famous drug. This is the new biological agent, and these biological agents are very, very expensive. Okay, these drugs are very expensive. In that, bevacizumab is one drug. Bevacizumab is one first drug, which is anti-VEGF antibody, and along with that, we have certain recombinant fusion protein, aflibercept, which is also called zivaflibercept, which targets the VEGF-A, VEGF-B, and platelet growth factor. Okay, VEGF is nothing but it is a vascular endothelial growth factor. Okay, so they will target these growth factors and they'll decrease the activity, and based on that, aflibercept is another biological agent. These are specific drugs. Okay, this is second. Aflibercept is second biological agent, very, very effective, recently approved for colorectal cancers. And along, the third one is ramucirumab. Okay, ramucirumab, this is anti-VEGFR2 antibody. Okay, it inhibits the binding of VEGF ligands to VEGF-A, VEGF-C, and VEGF-D. So third one is ramucirumab. You have to remember this. And fourth, we have two anti-EGR antibodies, cetuximab and panitumumab. Okay, these are another antibodies. And finally, we have one TKI inhibitor. In previous classes, we discussed about TKI inhibitor. In that, regorafenib is another biological agent, which is TKI inhibitor. Okay, so these are different biological agents that are used for colorectal cancer. Okay, so these are treatment strategies we follow in the hospital. I think you understood all basic concepts about colorectal cancer. Let me summarize. In colorectal cancer, we have discussed about the anatomical features of colon, anatomy of colon. In that, we have different stages of colon and rectum that we have seen, and we have discussed about the risk factors of colorectal cancer. We have discussed about diagnostic criteria and clinical presentations, and we have discussed two main mechanisms. Okay, pathophysiology, two main mechanisms, And finally we have discussed treatment, and in treatment we have Folfox regimen. Always remember Folfox 4 regimen. This regimen is important for colorectal cancer. And yeah, that's it. And in treatment, if you see, we have specific treatments, biological agents, and cytotoxic drugs, Folfox treatment. Okay, so that's it about colorectal cancer. I think you all understood about colorectal cancer. See, in colorectal cancer, if you see surgeries and radiotherapy, adjuvant therapy, supportive therapies, again, it is a very, very huge topic. So just for understanding purpose, I think these concepts are sufficient for you for writing exams. Okay, so that's it for today. These are basic things about colorectal cancer. Thank you for watching.